This talk is about insertional activity. As you know, the major component of muscle is the muscle fiber. In this frame, I have added a longitudinal histological cut specimen of striated muscle. I will use it in conjunction with the muscle cartoon to illustrate how insertional activity is generated. When the EMG needle is inserted in a muscle, the muscle fibers in the vicinity of the penetrating tip of the needle become irritated. This is represented in this frame by the dark color surrounding the needle in the muscle and now illustrated in the histological specimen. It is important to keep in mind what is obvious, that the number of muscle fibers irritated is related to the distance traveled by the needle through the muscle and the number of fibers per cubic millimeter in the particular muscle being studied. Once irritated, each muscle fiber undergoes depolarization of its sarcolemma. This mechanical depolarization of the sarcolemma produces in normal muscles a single, and notice the stress in the word single, action potential in each fiber, as illustrated here. The action potentials generated by the irritated fibers are captured by the tip of the needle electrode. Then they travel in both directions. When the needle goes further in, as represented in the muscle and now in the specimen, the action potentials of the initially irritated muscle fibers propagate away from the capturing field of the tip of the needle, and new action potentials are generated in the vicinity of the advancing tip of the needle. These new potentials are recorded. Once the needle stops, since no new action potentials are created and the propagating action potentials have traveled beyond the catch area of the electrode, there is no further recordable activity. It is the composite of these action potentials adding over the time the needle is moving and their disappearance once the needle stops moving that constitute the unquestionable normal insertional activity. This explanation brings up two questions about insertional activity. The first one is how many fibers are irritated when performing an EMG. An experimental study revealed that needle movements ranges from 1 to 5 millimeters during EMG testing. Such movements generate a burst of action potential that lasts less than 230 milliseconds. These values suggest that about 50 to 75 muscle fibers are irritated in the course of needle insertion during EMG, calculating that each action potential lasts 3 to 4 milliseconds. The second question is how long does it take for a just created action potential to propagate beyond the catch area of the tip of the electrode? This question was at least partially answered in a study done in 1977. This study was performed sampling the biceps brachialis of normal subjects, and its aim was to determine how long insertional activity lasted after the cessation of electrode movements. The result of this study suggested that the action potentials propagate beyond the catch area of the electrode in less than 70 milliseconds. Now, armed with this theoretical knowledge, let's talk about practical issues. And let's start by asking three questions. The first one is, what is the working definition of insertional activity? Insertional activity can be defined as any non-artifactual EMG activity present as the needle moves through the muscle and in the following first 3 seconds after we stop moving the needle. During this period, the prevalent activity is best judged while holding the needle up steady after each movement for a bit over 3 seconds before moving the needle again. The second question is what EMG settings are used to record insertional activity. The EMG settings used to record insertional activity includes a band pass limited by a low frequency filter set at 10 Hz and a high frequency filter set at 10 kHz. Sensitivity of 50 to 200 microvolts per division and a sweep of 100 to 300 milliseconds per division. The third question is, how is insertional activity classified? The short answer is in many different ways. Among them, the one I find most useful is the following. I like to classify insertional activity as normal, variant of normal, and abnormal. We will first talk about normal insertional activity. I define unquestionable normal insertional activity as one that allegedly follows the physiological sequence and termination we previously mentioned just a few minutes ago and that I have illustrated in this frame. One that is present in the great majority of normal individuals and therefore one that should be considered normal even when present in a patient with a disease known to be associated with abnormal insertional activity. This is an example of unquestionable normal insertional activity. The first needle indicates the time the needle crosses the cutaneous plane, the second needle the time the needle movement stops. Hence, as you can see, there is a burst of action potential lasting as long as the needle was moving and gone almost immediately after the movement of the needle ceased. Usually, when performed by an experienced EMGer, the insertional activity lasts for 300 to 500 milliseconds, reflecting the duration of needle movement. In this frame, you can see two examples of unquestionable normal insertional activity. Notice that the duration corresponds to the duration of the needle movement. On the other side of the fence of this restricted definition, we have the opinion of Dr. O. Dr. O stated in his book, Principles of Clinical Electromyography Case Study, that increased insertional activity alone without fibrillations, positive sharp waves, or myotonic potentials is not clinically important. This conclusion is not adhered to by other authors who consider such activity as possibly the initial or only sign of denervation in a very early radiculopathy or neurogenic disorder, when spontaneous pathological waveforms such as fibrillation potentials have not yet had time to develop. So we have talked about normal insertional activity. We will now talk about variants of normal. And in this group, we will mention two types of insertional activity. The first one is referred to as snap, crackle, pop because the sound generated when inserting the needle is similar to the one heard after pouring milk in a bowl of cereal. In addition to recognizing this activity by its peculiar sound, snap, crack, pop, insertional activity has visually identifiable characteristics, as you will see in the next few minutes. In this frame, you can see four insertional activities. The insertional activity indicated by the arrow has all the characteristics enumerated when we talked about unquestionable normal insertional activity. It is short, less than 300 milliseconds. We assume it stopped shortly after the needle movements had ceased and is immediately followed by a return to baseline. The other three are examples of a snap, crackle, pop insertional activity. Notice that in all three of them we see a dot followed by a bar. The activity under the dot corresponds to the burst, coinciding with the movement of the needle. The bar indicates no needle movement, and as you can see, while the needle is not moving, there is a run of potentials lasting for about 1 second. These potentials occurred irregularly, and each potential has different amplitudes, as you can see. This activity was found in 5% of patients studied by Dr. Wilborn. It was not associated with any disease. Males, especially robust males, were affected more often than females. This pattern of insertional activity was usually present in at least 2 limbs, and it was found most often in the medial gastrocnemius, but also frequently in the flexor digitorum longus, but rarely in the glutei. In the same paper, the components of the post-burst activity were broken down, and as you can see here, they are all very different in amplitude and configuration. The author hypothesized that the snap, crackle, pop type of insertional activity may be caused by mechanical movement of connective tissue planes produced by the needle tip and the activation of muscle spindles and tendon organs. The benign nature of the second so-called normal insertional activity variant is more questionable. This activity consists of a normal burst generated while the needle is being moved, followed, once the needle movement stops, by a brief transient run of positive waves that persist, usually for less than 1 second. This activity is often present in multiple muscles of healthy individuals, yet a similar pattern has been found in patients with mild cases of myotonic dystrophy type 2 and myotonia congenita. Hence, some EMGers consider it, that is, this activity, a bad omen, and even in patients referred to the lab for unrelated conditions as those mentioned, once this abnormality is found, the patient is referred for a genetic consultation. Now we have talked about normal variants. We will talk about the third type. This type is the abnormal insertional activity. Insertional activity can be abnormal because it being decreased or increased. Decreased insertional activity may be due to a paucity of muscle fibers in the path of the advancing needle or the presence of muscle fibers with decreased propensity to produce action potentials. The extreme of this situation is the absence of insertional activity, as represented in this figure, where you see no activity while the needle is being moved nor after. Absence insertional activity is seen in patients with familiar periodic paralysis during the paralysis and in patients with myocardial disease in the contracting muscle. In a less extreme situation, when the insertional activity is short-lasting, that is, the activity is initially present when the needle is first inserted but ceases while the needle is still being moved, we should consider three possibilities: fat infiltration of muscle tissue, as you can see in the upper part of this specimen, fibrosis, as you can see widespread in this specimen, or edema between muscle fibers. In the next frame, you will see a video showing a decreased insertional activity. The first part of the video is silent. The second part adds a brief oral explanation. The video lasts for about 1 minute.
An example of decreased insertional activity is depicted. Note the reduction in the electrical activity associated with needle insertion. This is quite unlike normal insertional activity.
Now we're going to talk about increased insertional activity. Increased insertional activity is either due to increased number of muscle fibers per cubic millimeter of muscle, or muscle fibers that instead of only discharging once after mechanical stimulation by the needle, discharge many times. Increased insertional activity occurs in patients with myopathies of different types and neuropathy. In this frame, you can see an example of minimal increased insertional activity. The insertional activity is present for about 300 milliseconds after the needle stops moving. This is the type of increased insertional activity Dr. O will probably consider normal. In this new example, we can see that the increased insertional activity is present after the needle movement stops and it lasts beyond the window. This activity is unquestionably abnormal. The last type of increased insertional activity I will show you is characterized by a relative normal burst while the needle is moving, but is followed by a run of fibrillation or positive sharp waves despite the needle not moving, as indicated here by the parenthesis. In the next frame, you will see a video showing increased insertional activity. The first part of the video is silent. The second part adds a brief oral explanation. The video lasts for less than 1 minute.
An example of increased insertional activity is demonstrated. Note the initial insertion of the electrode and the persistence of electrical activity following cessation of needle movement. In this case, we see what appears to be a series of positive sharp waves following the needle insertion.
Thank you very much for your attention.